So now we've finished in our bathroom, and we've done all of those pieces and looked at all of those M questions. And now we're going to walk to the bedroom for a physical assessment. We're going to ask the patient to show us the bedroom or where they sleep. We want to assess that environment. We want to ask the patient to undress to facilitate a physical assessment. Again, we're looking at undressing, taking off the blouse, the sweater, the shirt, taking off pants, taking off hosiery, or taking off shoes. So we want to facilitate the assessment. We ask the person to lay down on the bed and then roll to the side. We can assess their turning themselves. How able are they to do that? How able are they to lay down in the bed? How able are they to get up from the bed from a laying down position? We want to then ask them, when we finish their physical assessment, if they can, ask the patient to redress and return to the living area. And we want to look at how the patient is dressed. Are their zippers zipped? Are their buttons buttoned correctly, aligned up? I do that incorrectly sometimes, so I do this with a little grain of salt. But if I see the person, really doesn't notice that they're, a button off and that things are crooked and pulling, I start to question. So again, we're assessing all of these things, any pain when they're moving, frequency, how is it, and we can ask them, what is your pain level at this point in time, and have them give us a number. Whether they're short of breath even doing this, that physical exertion of rolling over or laying down or getting up, does it cause a shortness of breath? Any respiratory treatments we can look at that point in time. Do they have any? You may see it in the bedroom area, a nebulizer, or if they have oxygen tanks, they may be in the bedroom. Are they confused or anxious doing this? Do they understand what we're saying to them? Do they do a different command than what we've asked them to do? I've seen people, I tell them to lay down, and they stand up. They've been sitting on the bed. I tell them to lay down, they stand up. And now I'm wondering, can they hear correctly? Or more than likely, do they have some cognitive deficits, and they may be trying to cover it up? We've looked at grooming. We've looked at the ability to dress the upper body, the lower body, and bathing, and transferring from bed to chair, and ambulation and locomotion. So we've, again, assessed all of those M questions just by doing this. We look at wound care questions. When we do the assessment, we can assess the skin condition. It is required, of course, in the regulations, any presence of wounds. We have to do a full body assessment, again, required. So again, part of putting forth our care plan is that we do this full body assessment and look at the skin for any wounds. So how many Oasis C items can be answered after these 6 tasks? There are 98 Oasis C items. We can answer 43 of them of this. So it's approximately 50% at this point, well, a little bit less than 50% at this point in time. How many are left? So there's 55 out of 98 Oasis C items are left. 22 of the 55 are demographic items. In other words, we would answer them, but they are not part of the assessment. And a lot of them are patient tracking items, and they are more than likely auto-populated by your electronic medical record, if you have an electronic medical record. And some of those are the CMS certification number, or your provider number, your branch state, your branch ID number, patient episode number, the start of care date, resumption of care. All of those early moves are usually populated by the EMR, and you don't even need to think about them. So you may have to answer MU 150 based upon your knowledge of what you get on the referral and the cards you see in the house when you look at the insurance and have the person sign consents. Now, on the clinical record, these items are not patient assessment items. The discipline of the person completing the assessment, whether it's an RN or a PT, MU 90, the date the assessment's completed, and then why you're completing the assessment itself, MU 100. the date of the physician-ordered start of care or resumption of care, the date of the referral, and episode timing, whether it's early or late. They're not patient assessment items. Patient history items, you're going to get these as to why the person is needing home care, were they discharged from an inpatient facility. So some of these you will have to fill in based upon your knowledge base, but they're not assessment items. Living arrangements, this is the environment that you're looking at. You're going to know from really your assessment who the person lives with and whether or not the person gets assistance, either from that person or outside people. The neuro, emotional, and behavioral status, we do a depression screening that is filled in on the Oasis. We do look at cognitive, behavioral, and psychiatric systems, frequency of disruptive behavior, and psychiatric nursing systems. All of these are, they're probably can be incorporated into part of your assessment, but there may need to be interaction with the patient with this to fill these out correctly. We look at the prior functioning. That's something that can be asked on the interaction, or you can be talking with the caregiver on this. But certainly it's something that can be incorporated into your assessment. And again, a multi-factor full risk assessment that you're doing, that can be incorporated into the assessment, whether you do a mock 10 or a TUG. The care management, the types and sources of assistance and the frequency of assistance, really done through interaction. And again, the therapy need and the plan of care for therapy, that would be dependent on the agency and how they hold these questions. And if there is a therapy need, is an evaluation done before the Oasis 2250 is filled out, or is only evaluation put in? Every agency has a different take on this and does it differently, so that would be left to your individual agency. So, in conclusion, the Oasis is a good tool. It really is a good tool to see the ability and function of patients, and really, as much as possible, to place into staff's minds that it shouldn't be looked upon as paperwork to complete in the shortest time possible. And those interactions, observations, and measurements that I've described previously provide you most of the input to complete the Oasis, and the data will be accurate. The last 4 words, the data will be accurate. The last 5 words, the data will be accurate. That's the most important thing, and I believe that from doing this IOMs, you will have the most accurate data that you possibly can have, because it takes into account your talking with the patient, your observation of the patient, and doing your measurements that you need to do, and then using your clinician's mind and eye to document all that you see. And again, you see the abilities of the patient, you utilize your clinician critical thinking skills, and really don't give a lot of wiggle room. Well, maybe he could do this if. It is what it is that day. You want to piece together your observations. You come to a conclusion and a decision. You look at the patient from a wellness perspective and look at how that patient deviates from that wellness perspective that you have. And what goals can you achieve with this particular patient in this particular episode? Sometimes the goals are going to be incremental. Sometimes stabilization is the goal. And if you accomplish that, you have done, a great thing in the agency, and it's what home care is about. So we have to look at individual goals for every patient. We want to make sure that the plan of care that we develop provides the most appropriate service at that particular point in time for that patient. So we want to have appropriate outcomes for that patient that show the value of home care. You won't get that if you don't collect accurate data on your Oasis. And again, when you fill out your Oasis, there are a number of questions that pertain to Medicare payment as well as to risk management and quality. So that those questions filled out incorrectly can impact the appropriate reimbursement for that particular patient. And again, because home care is home care, I always see home care give the services no matter what. So that, again, if the data wasn't filled out accurately, but the need is there, the services are given, but the most appropriate reimbursement for those services is not being achieved by the organization. Now, this is a reference list on the home health conditions of participation in the Oasis C guidance manual. This is where we get our information from. And they're good websites to keep in your favorites area, so that when you need that information, you can go and click very easily and get to it very quickly. So I hope I haven't been too quick, and are there any questions for me?
Okay. Thank you, Laura.